Go ahead.
My topic is fluid responsiveness in mechanically ventilated patients. Administration of intravenous fluids correcting hypovolemia, it increase venous return and cardiac preload and increase cardiac output. Intravenous infusion not always correcting tissue hypoxia and neither to control cardiovascular instability. In some patients, increased cardiac output after fluid administration are called fluid responders. That is, fluid responder is increased stroke volume of 10 to 15% after administration of 500 ml of crystalloids in 10 to 15 minutes. In some patients not respond to fluid administration, that is called, are likely to develop fluid overload. Measurements of fluid responsiveness, either static measurements and dynamic measurements. Static measurements is estimation of ventricular preload. It will measure central venous pressure, pulmonary artery occlusion pressure, IVC diameter, global end diastolic volume index, left ventricle end diastolic area. In dynamic measures, estimation of variation in hemodynamic measurement in response to changes in cardiac loading conditions like stroke volume variation, pulse pressure variation, aortic flow velocity, mixed venous oxygen saturation, um, positive pressure ventilation induced changes in vena cable diameter. In fluid challenge will do passive leg rise test. It is easy to perform at bedside. Principal, position a patient flat 0 degree, then rising to 45 degree quickly for 30 to 90 seconds to reservoir of approximately 300 ml of venous blood to central circulation. Patient must be able to passively elevate legs. Protocol: measurement of cardiac output while semi-recumbent position to 45 degree and lower the body, elevate the legs to 45 degree for 1 minute and repeat cardiac output measurement. Results: more than 10% increase in cardiac output in passive leg rise test predicts the fluid responsive. In fluid challenge, change in preload in relation to change in stroke volume, cardiac output, and dynamic indices. It depends on type of fluid, rate of administration, and objectives and limit for safety. In type of fluid, depends on clinical condition. Crystalloids are usually preferred. Blood products may be used in patients with severe hemorrhage. Albumin may be useful in sepsis and is contraindicated in traumatic brain injury. Rate of fluid bolus, usually 500 ml of fluid over 20 to 30 minutes. Objectives are target mean arterial pressure is 65 mm of mercury. Target urine output is around 0.5 ml per kg per hour. Resolution of end organ malperfusion, resolution of tachycardia, improved loss of consciousness, falling lactate, rising SV, venous oxygen saturation, and cardiac output monitoring. Mini bolus or micro bolus. Uh, it is rapid infusion of 50 to 100 ml of fluid can predict the response to a larger bolus. Protocol: 50 ml over 1 minute as micro bolus or 100 ml over 1 minute as mini bolus. Result: it is a 10% increase in cardiac output immediately after bolus suggest of the fluid response. High PEEP challenge. Um, in mechanical ventilated patient, increased PEEP with decreased mean arterial pressure identified fluid response. Protocol: if it is increased PEEP from 10 to 20 centimeter of water for 1 minute leads to 8% decreased MAP or 10% decreased cardiac output such as fluid response. End expiratory occlusion test or difference between Valsalva. From, for mechanical ventilated patient, interpreting mechanical ventilation at 15 seconds of apnea transiently and increased preload or 5% increased in cardiac output during end expiratory occlusion is suggestive of fluid response. Prerequisite: mechanically ventilated patient is tidal volume at least 8 ml per kg, able to tolerate 15 seconds of apnea, continuous cardiac output measurement. Patient should not have spontaneous efforts and low lung complaints or cardiac arrhythmias. We'll go for static measurements details. Central venous pressure. Central venous pressure, it requires a catheter placed in superior vena cava near the right atrium junction. Corresponds to right atrial pressure. It is surrogate for right ventricle filling pressure. It is not a reliable factor since it is affected by volume status, right ventricle function, tricuspid valve function, pulmonary valve function. According to Frank Starling relationship, stroke volume is increased with CVP until a plateau is reached. However, in fluid responder, the administration of fluid increased blood volume, it increased cardiac output, so minimal increase in CVP. In non-fluid responder, same as fluid responder, increased blood volume, but no change in cardiac output, major change in central venous pressure. So, in increased central venous pressure cannot be used to suggest a positive response to fluids. Pulmonary artery occlusion pressure. It requires pulmonary artery catheter to measure the pulmonary artery occlusion pressure. It it is corresponding to the left ventricle end diastolic pressure. Insert a pulmonary artery catheter in an invasive procedure with the risk of arrhythmias, pulmonary infarction, and rupture of the vessel. So it is not recommended usually in critically ill patient. Left ventricle end diastolic area that is measured in right parasternal short axis view at the level of the mid papillary muscles is commonly used to estimate volume status. In normal left ventricle end diastolic volume by echo is 80 to 130 ml and left ventricle end diastolic volume index is 55 to 65 ml per meter squared. If it is less than 10 centimeter square, left less than 10 centimeter square, it indicates hypovolemia. It ranges in short axis 9.5 to 22 centimeter square. In exception, severe concentric LV left ventricle end diastolic area is even less without hypovolemia. Next is global end diastolic volume and intrathoracic blood volume. It measured by transpulmonary thermodilution technique uses injection of cold saline solution and a thermistor tipped arterial catheter to estimate the maximum cardiac, that is four chamber volume is termed as global end diastolic volume. Intrathoracic blood volume mathematically is calculated by global end diastolic volume into 1.25, which represents the sum of global end diastolic volume and the pulmonary blood volume, is also a accurate predictor of fluid response. In IVC diameter, IVC diameter changes in relation to preload. It corresponds to the right atrial filling pressure. IVC diameter is measured through ultrasound, determines length from the right atrial cavity during the expected time. Factors affecting IVC diameter measurement is obesity, lung hyperinflation, pneumothorax, and the intra-abdominal pressure increased more than 12 mm of mercury. It is unsatisfying for sonographic windows. So normal IVC diameter is 1.5 to 2.5 centimeter. If it is less than 1 centimeter, volume depletion is more than 2.5 centimeters, volume overload. Dynamic parameters. IVC distensibility index is defined as change in IVC size with respiration. In usually spontaneously breathing patient during inspiration, because of negative thoracic pressure, increased venous return. So IVC diameter is decreased for about 50%. In mechanically ventilated patient, it is cyclical changes. Like in inspirative phases, it increased, and in expirative phases, it is decreased. IVC distensibility index is calculated by difference between value of maximum diameter and minimum diameter divided by mean of two values. If it is more than 12%, it is likely to respond to the vascular filling. Pulse pressure variation. Pulse pressure varies. What is pulse pressure? Pulse pressure is difference between systolic and diastolic pressure. It is surrogate of stroke volume. So pulse pressure is directly proportional to stroke volume and inversely proportional to the arterial compliance. Pulse pressure variation is calculated by difference between maximum and minimum pulse pressure over single mechanical breath, a, a normalized mean of two values and expressed as a percentage. Pulse pressure variation is more than 13% is responsiveness, fluid responsive. Pulse contour analysis. It is analysis of arterial waveform. This allows beat to beat measurement of stroke volume. 10 to 15% it suggests pulse counter fluid response. Next topic is the respiratory variation in aortic blood velocity. It measures outflow of blood from left ventricle and combined with challenge maneuver. In LVOT, velocity is recorded by ECG by pulsed wave Doppler at the level of aortic annulus. So respiratory variation of LVOT more than 12% it indicates fluid response. In mixed venous oxygen saturation, um, around 2% around 2% increased cardiac output for fluid challenge. It suggests of the fluid response. Thank you, sir.
Finished?
Yes, sir.
Right. Why we have to know about the fluid responsiveness in mechanically ventilated patients? Why are we not worried about it in a patient breathing spontaneously?
For cardiac, the mechanical is more prone for cardiac instability, like decrease.
Is it because of that, or is it because of the changes in the intrathoracic
Pressure.
pressure?
Because of intrathoracic pressure, the pleural pressure and the right atrial pressure, everything will decrease, sir. So venous return also will decrease.
So the main difference between a spontaneously breathing patient and a mechanically ventilated patient is the normal pattern of negative intrathoracic pressure created during inspiration is abolished when you intubate and mechanically ventilate the patient. The whole cycle becomes a positive pressure all the time. So in order to ascertain whether the patient will respond to fluid challenge or not is a problem because of this particular change in the intrathoracic pressure. And the second reason we always try to do the fluid responsiveness is based on the physiological fact that heart lung interaction should be always normal. Then only the responsiveness will be seen. For example, if a patient is in a cardiogenic shock, however much you try to give fluid, if the heart is not able to pump, will you see a fluid response in this patient?
No, sir.
So the heart lung, the two important points you have to remember as a basis for this particular topic of responsiveness to fluid challenge in a mechanically ventilated patient are: one is we are altering the normal physiology of negative pressure during inspiration into positive pressure both during inspiration and expiration. And the second thing is there should be a normal heart-lung interaction to assess fluid responsiveness. If the heart is not pumping well, or if the lung is very much fibrosed, or if there is a pulmonary vessel alteration, in those cases, to assess the fluid responsiveness is very, very difficult. So in all those patients, we presume that there is a normal heart-lung interaction, and that is the reason why we do this. And you describe them correctly in two categories like dynamic parameters to assess the responsiveness and static parameters. Earlier, we were depending only on static parameters like CVP, PCWP, and POP, and all those things. But of late, they have found that the static parameters show a particular value only at the time we measure. It is not showing the continuous activity of the heart and lungs. So the reliance on the static parameters to assess the fluid responsiveness is now become more obsolete, and we are depending more on the dynamic parameters only as a measure of assessing the fluid responsiveness, of which they initially started with the pulse pressure variation, which is a surrogate of stroke volume. So the stroke volume is the most ultimate thing that we want to achieve, because if you have only a proper preload to the right side and the proper preload to the left side, you will have adequate stroke volume, which will be ultimately taken to the tissues. And the aim of fluid responsiveness is to deliver adequate amount of oxygen to the tissues. That is our ultimate goal. So that can be achieved only by proper interaction of these two systems, and to see whether they will respond by giving the fluid to avoid overloading the patient and causing a pulmonary edema, or underloading the patient and causing inadequate cardiac output and saturation. So this is the reason why we want to see in a patient who is likely to be hypovolemic by giving fluids whether we can improve the cardiac output or stroke volume and achieve the ultimate target of tissue oxygenation. That is the reason why this topic is given. and you have dealt it in good detail.